Good evening, ladies and gentlemen, and welcome to Battling and Beating Cancer here on CAN TV 21 in Chicago, and streaming live all over the world at cantv.org/live. So wherever you're watching us, I'm Scott Seaman, and along with Charlene, who's not here tonight, we're co-founders of Chicago Blood Cancer Foundation, which is committed to curing the blood cancers, lymphoma, leukemia, and myeloma. And you can reach us at www.chicagobloodcancer.org or at 888-792-9992. And you can like our Facebook page and keep updated on information, including upcoming episodes of Battling and Beating Cancer. This is part 2 of our blood cancer extravaganza. Last week, Dr. Gregory covered Hodgkin lymphoma, and we talked about a couple of the big forms of the more than 60 types of non-Hodgkin lymphoma. We talked about large diffuse B-cell, which is the most common lymphoma overall. And then we talked about follicular lymphoma, which is the most common indolent or slow-growing lymphoma. And you'll remember that the B-cell, large diffuse B-cell, is an aggressive or fast-growing lymphoma. And so we are going to spend some time tonight finishing up and talking about some more of the types of lymphoma, the B cells, and then we're going to talk about a different type of lymphoma, the B cell lymphomas, and then we're going to graduate into the leukemias. So we're really talking all about blood cancer tonight on Battling and Beating Cancer, and it's our privilege to welcome back Dr. Stephanie Gregory.
It's a pleasure to be here.
And she, as you'll recall from last week, still is the Elodia Kehm Professor of Medicine at Rush University Cancer Center and Rush University Medical Center, Professor of Medicine, Head of Hematology Oncology, and one of the top 1% of hematologists, oncologists in the world, and also a fabulous educator, because what you do so well is explain. You do, and you explain it so well, and you make the patients feel so much more informed. And an informed patient is a patient that's going to do better because they understand,
conquer their disease.
They'll understand the options, they'll make the better decisions, and they'll sort of know what's in store for them.
It's important. I think that sometimes physicians are so busy and they have so many patients in the office, and, patients need to hear it over and over again. They can't grasp everything on the first visit or the second visit, and I think repetition is so important. And I always say, please come in with your list of questions, because they're going to forget. You walk out and they say, I forgot to ask my doctor that. So,
absolutely.
Important.
Bring your questions with you.
Written down.
Write them down. Sometimes if you're not good at taking notes, bring a little tape recorder or have somebody with you, because they'll pick up on things that maybe you don't catch, because sometimes all of this is overwhelming. And that's just part of being an informed patient. And the good doctors will take the time with you. And if they don't have the time right then and there, they will get back to you, or they'll make arrangements to get the information. And then there's organizations like Chicago Blood Cancer Foundation where we do have the time, where we can give you some additional information. And whenever you get information, whether it's from the web or an organization or a paper, it's good information to have, but check it against your doctor, because you have to put it in context, because you read a lot of things that are inaccurate, you read a lot of things that don't apply to you, or you read something.
And a lot's outdated.
Yeah. And there are so many exciting developments, particularly with the lymphomas. And let's just pick up where we left off, and there's another type of lymphoma called mantle cell lymphoma.
Right. And so last week we did talk that there are about 70,000 new cases of lymphoma a year. Most common is one that's very curable, diffuse large B-cell, about 30%, 35% of the lymphomas. The second most common is the follicular, which is usually more chronic and can live a long time with it. We try not to over-treat that if we don't have to, and that accounts for about 22% of the lymphomas. Then there are the lymphomas that are a little bit more rare, and mantle cell lymphoma accounts for only about 6% of all of the lymphomas. And sometimes we say the mantle cell lymphoma is a mix between the aggressive lymphomas and the indolent lymphomas. Aggressive in that if you don't treat it, you may die quickly. Indolent in that, in general, it's not curative. But what we've learned is not all mantle cell lymphomas are really aggressive, and not all mantle cells need aggressive treatment up front. So the mantle cell lymphoma, again, is a non-Hodgkin lymphoma. It will present in the same way as the other lymphomas, usually a painful enlargement of a lymph node someplace. And it actually sometimes can be quite indolent. It may mimic some of the other lymphomas, and it actually can mimic one of the leukemias, which I think we'll talk about later, called chronic lymphocytic leukemia. A lot of work has been done with mantle cell lymphoma at the MD Anderson Center, and they actually developed a fairly aggressive treatment regimen called the hyper-CVAD regimen. They add the new monoclonal antibody called Rituxan to that, and they've actually prolonged the life of many patients by then moving those patients on to a high-dose chemotherapy and rescue using the patient's own bone marrow stem cells, and that's called an auto transplant.
We had Dr. Fung on from last season, and people
yeah.
can go and look at the tape, and he talked all about stem cell transplants and the different types, but also the progress in terms of, for many
safety
years, yes, lots of potential side effects, and it's so much different today.
Yes.
And to transplant patients, even in their 70s
yes.
today is...
And there are different types of transplants. So this is really not surgery. It's not getting something from a donor. There is a type of a transplant that you do have to use a donor in. But we talk mostly about these transplants that you use the patient's own bone marrow stem cells. And, aside from having to be in the hospital for about 2 weeks, most patients do quite well. And it's not a terribly, terribly toxic procedure.
And the good news about a transplant is if it's successful, many times it results in a cure. It basically gives the patient a new immune system.
Now, with mantle cell, even though we said it's not in general curative, there have been some aggressive protocols. There's something called the Nordic protocol, and they are claiming that now they are having patients with mantle cell go a very long time after transplant. But what we've learned is that not every patient with mantle cell lymphoma needs that aggressive treatment. The other thing is a lot of the patients with mantle cell lymphoma are over the age of 65, and they cannot tolerate this aggressive treatment that I just talked about that was developed at MD Anderson. And so we're looking at many of these patients receiving less toxic treatment. Some of the newer drugs that are being approved for, say, mantle cell lymphoma that comes back are not as toxic. One is called Velcade Bortezomib. We talked about that last week. And some exciting data came out of the American Society of Hematology meetings in December. Remember, we called it ASH last week.
Not ashtray.
ASH, right, not ashtray. And the newer treatments are drugs called Lenalidomide and also some pathway inhibitors. One that looks very promising, and it's a pill called BTK inhibitor, Bruton's tyrosine kinase inhibitor. These are not yet approved, but the lenalidomide, I believe the company has already applied to the FDA to see if it might be approved for relapsed mantle cell. So some promising approaches to really a disease that years ago everybody thought was a death sentence if you had that diagnosis. It no longer really is.
So you would think logically if we had and all the lymphomas we talked about on last week's episode and the one we just talked about are called B-cell lymphomas. So logically you'd think we should go to C-cell lymphomas, but we don't. There's another type of lymphoma called T-cell lymphoma, and it's actually a less common form overall than the B-cells, especially in the United States, more common in the Far East. But T-cell lymphomas, and they're really wide-ranging type, a lot
I'm
of
laughing
variety.
Because that was cute, Scott.
Every once in a while I'll get a laugh, but
B
not.
to C. Yeah. Okay. Well, the reason it's T-cell is that the lymphocytes, which are the immune cells, are derived from either the bone marrow, B-cell, or what was called the thymus gland, which is the T cells.
Okay, it's somewhere in here because that's where my cancer started.
That's right. So that's how the cells were called B or T cells, and they're very, very important in different parts of the immune system. The T cell lymphomas are quite rare. They account for 10 to 15% of all of the lymphomas. They again are a variety of the non-Hodgkin lymphomas, and because they're much rarer, a lot of physicians don't see them, and they're not that familiar with them. The T-cell lymphomas, again, they can be very indolent, or they can be very aggressive. And the most common indolent T-cell lymphoma is called the cutaneous T-cell lymphoma group, and those are lymphomas that occur in the skin. And so the dermatologists see those a lot, and they are very chronic diseases. Patients may go years before they're even diagnosed, and some of them are actually confused with psoriasis. And a variant of this cutaneous T-cell lymphoma is called mycosis fungoides.
I'm not even going to try that. I mean, it would sound like actually something that might be good to eat, but probably not.
All right. I won't go into how that was named, but and so the dermatologists will see these, and there are many dermatologists that are experts in cutaneous T-cell lymphomas. Most of the treatment for years is topical treatment, local therapy to the skin, sometimes as simple as steroid therapy. Others sometimes called PUVA therapy, which is ultraviolet light therapy. And the disease can progress. It can go into the lymph nodes and it can become systemic. It's rarer. And now we have, that's when the hematologist or oncologist gets to see the patient. And there are some new drugs that are approved for that. Then there's a group of T-cell lymphomas that are very aggressive. They start in the lymph nodes. And the most common one is called peripheral T-cell lymphoma, NOS, not otherwise specified, PTCL NOS. And that's the most common aggressive T-cell lymphoma. Those patients, we have treated those with CHOP, similar to what you've used in the B-cell lymphomas. You obviously don't use the Rituxan, the R-CHOP, because they don't have that marker on the surface of the cell called the CD20. CHOP's not that effective in the T-cell lymphoma, so we're looking at novel therapies, and those patients often will go right on to high-dose therapy and auto transplant.
And what's interesting is a lot of patients, well, I have lymphoma, and that doesn't tell you very much. You got to know
the type.
What type and what subtype, and then some more information such
Absolutely.
as what stage and degree, and because the lymphomas are very different diseases in some cases, the treatments can be different, but yet as different as they can be, for a lot of the T cells, which are rarer, a lot of the treatments, at least where we're at today, are based on the B cell lymphoma
That's
treatments.
Absolutely. We should comment that there is one, what's called an aggressive T-cell lymphoma that's very, very treatable, and it has cure rates similar to the diffuse large B cell, and that's called anaplastic large cell, and it is a T-cell lymphoma, but instead of having the markers that the B cells have, this one has a CD30 marker on the surface of the cell. Remember we said the B cells have the CD20, and that's why we use rituximab. Well, this anaplastic large cell has a marker called the CD30, and it's very curable with CHOP in general. But if patients relapse, there's now a brand new drug that's been approved for the relapse setting that's very effective, and it's a drug we talked about last week for Hodgkin lymphoma in the relapse setting, and that's called brentuximab vedotin, and a new exciting monoclonal antibody that is not terribly toxic. Hair doesn't fall out, given once every 3 weeks. A very effective new drug.
Has radioimmunotherapy been tried at all on the T-cell lymphomas?
No, it has. I shouldn't say that. I think that in general, there is not an approved drug for radioimmunotherapy. They'd have to target the markers on the surface of the cell, and that has not been developed.
All right, so we've spent time last week in the first half of this show really covering a lot of ground on lymphomas, and we said that there's 3 types of blood cancers, lymphomas being the first group. The second group is leukemia, and like lymphomas, not just one type, but as we transition through, there's a type of disease that in some cases it's considered lymphoma, sometimes it's considered leukemia. It's kind of a hybrid. It's CLL, chronic
Lymphocytic leukemia,
or SLL, small
lymphocytic lymphoma. So thank you. That was a nice transition into the leukemias. But we do consider the SLL, small lymphocytic lymphoma, as one of the non-Hodgkin's lymphomas. Again, it occurs similar to the mantle cell, 6-8% of all the lymphomas. These are very small cells. They're in the lymph nodes. They're in the bone marrow. When those bone marrow cells get so numerous that they spill out into the peripheral blood, and you have a high white count made up mainly of lymphocytes, by definition that becomes chronic lymphocytic leukemia. Patients can present either with the first disease, small lymphocytic lymphoma, and evolve into chronic lymphocytic leukemia, or they can just present with a high lymphocyte count, a high white count, Often it's found incidentally. I see 1 to 2 new cases of chronic lymphocytic leukemia a week, usually referred by the primary care doctor who has seen the patient for their routine yearly exam and does a blood count. And all of a sudden the white count, instead of being within the 5 to 10,000 range, which is normal, the doctor finds the white count of 15 to 20,000. The cell count comes back, called the differential, and he sees that most of the cells now are lymphocytes, and that's not normal. You should only have about 40% of the cells being lymphocytes. And so he refers to a hematologist or an oncologist. Now, you can't just make the diagnosis today by having a high white count and mostly lymphocytes. The classification has changed. We have to do certain studies to show that those lymphocytes are malignant, and that's done by a test called flow cytometry. And that tells us that the lymphocytes are malignant lymphocytes. And that's how we make the diagnosis, by just a peripheral blood sample.
So basically with the lymphomas, we talked about the diagnosis ultimately being the tissue, getting a biopsy, having a pathologist look at it. It's important that it's done right. It's important when we talk about second opinions. People oftentimes neglect to get a second opinion on the pathology. You need to take the sample itself to your second institution, have their hemopathologist look at it, get that second opinion. And for the leukemias, it's more or less a blood test or series of blood tests.
Yes.
And so for people with CLL, what are the symptoms? What's the course? And I know there's a lot of variance in the course of the disease. And
so we do consider chronic lymphocytic leukemia as, again, a low-grade lymphoma. It's not curable in general. It is a disease of the older population. The median age of onset is 72 years of age. And so a lot of these patients, as I said, it was found incidentally, and many of them do not require treatment. Years ago, we used to say, oh, don't worry, you'll die from another problem, probably a heart disease. Well, you know, today we're doing bypass surgery on 90-year-olds, and we're doing transplants up to age 70. So people are living longer, and so if they develop their chronic lymphocytic leukemia at age 72, they may live till 94, and they may need treatment for their chronic lymphocytic leukemia. There are prognostic markers, and so we can sort of prognosticate to the patient early on whether they may need treatment or not need treatment in the next 3 to 5 years. And a lot of these prognostic markers are just by, again, taking a sample of the blood, we send it to the laboratory, and we actually look for certain chromosome abnormalities. And they are the biggest and best way of prognosticating whether the patient may have a shorter course or a longer course of their disease. And again, if the patient is asymptomatic, you do not treat.
Watch and wait, like follicular
and we always say physician do no harm. And that really means don't overtreat some of these diseases that really are chronic.
We say the same thing about lawyers, but they do a lot more harm.
My husband's a lawyer, remember?
I know.
Yeah.
So we, when we talk about CLL, and it's usually older patients, but not always, but there have been really some exciting developments in the treatment in the last 2 or 3 years. Could you?
Yes, absolutely. So, you know, the major treatment has been out there has been a pretty aggressive combination of 3 drugs. One is called fludarabine, another is Cytoxan, and then you add the R drug, the Rituxan, to it. It's been called the FCR regimen. And very, very high response rates, up to 80-90% response rates. A lot of those patients are in complete remissions, and a lot of them don't need treatment for another 4 or 5 years. But when you look at those studies, the patients who were put on those studies, the median age was something like 55 years of age. So you have to realize older patients in general don't go on clinical trials, and it's the older patients that get the disease. So when we looked at some of these aggressive treatments, the older patients couldn't tolerate them. And so, excuse me, again, we're moving away from chemotherapy. And one of the drugs that is very effective is the same drug I mentioned for mantle cell lymphoma, lenalidomide. It's called an immune modulatory drug. It modifies the cancer cell, and it modifies the environment of the cancer cell. Remember, seed is the cancer, soil is the microenvironment that feeds the cancer cell and makes it grow. So this new drug, or it's really an old drug derived from the drug called thalidomide years ago, I think some of you may be familiar with that. It was now found to be a very potent anti-cancer drug, and lenalidomide is about 1,000 times more potent as a cancer drug than the original drug called thalidomide. And it is a pill. It is a pill. A few side effects. Blood counts have to be followed. You have to watch out for some deep vein blood clots, so you take a baby aspirin when you're on it. But we combine that now with Rituxan, the monoclonal antibody, and it is actually replacing chemotherapy in some patients. It is not yet approved for chronic lymphocytic leukemia. So again, these are some novel agents that are on their way, hopefully, to be approved.
And maybe in some instances available to patients
Yes,
right now in clinical trials.
Absolutely, and they are. The other drug is the same drug we talked about that is being used in relapsed mantle cell lymphoma. It's these pathway inhibitors, and the one that's so effective is called the BTK inhibitor, the Bruton's tyrosine kinase inhibitor. It's a pill. It's in clinical trials, adding it to the drug we talked about last week, which came from Germany, bendamustine. And so bendamustine and Rituxan and these oral inhibitors are being added together for the treatment of chronic lymphocytic leukemia. Again, all these newer drugs are often used after the patient's had standard treatment. So they're often used in the relapse setting when the disease comes back. Hopefully, we'll be able to get them approved, and they'll be moved up
as a frontline
treatment.
Yeah. So we've talked about it, CLL, one of the chronic leukemias.
Yes.
The other chronic leukemia is CML, and it's another sort of heroic example of, really not only that blood cancer research being the superhighway to curing cancer, but that superhighway running right here through Chicago, because the work in Chicago turned this disease that used to be, frankly, a death sentence for people diagnosed with CML a couple decades ago into a disease where people are living 15, 20 years plus, and we don't even know how much longer, maybe even cured.
We may be curing them with a pill.
With a pill.
With a pill. So
called Gleevec, but also newer drugs.
Yes. So when I trained for hematology, chronic myelogenous leukemia, so the myeloid cells are a different type of white cells. They're the so-called the neutrophils, and they're a different kind of a fighter cells for the body. Chronic myelogenous leukemia is a disease of a little bit younger population, not often seen in the 80-year-olds, but you can see it in a 40-year-old, 50-year-old. And when I was in training, the only way we could ever cure a patient with chronic myelogenous leukemia is if they had a brother or sister whose bone marrow matched them, and they got what's called an allo transplant, carried with it about a 30 to 40% mortality, and we cured maybe 50% of the patients that were able to go on to a transplant. Today, this disease is probably going to be curable with a drug called Gleevec, and now there are second and third generation Gleevecs. Another one is called Sprycel, another is called Lenalidomide, and we have 5 or 6 new drugs. These are called tyrosine kinase inhibitors. Some have another mechanism called SRC inhibition, and we are really being able to have patients maintained in remission for years and years and years with a single pill every day. There are a few side effects to them. Patients will become resistant to some of the first line pills that we use, so you go to the second generation tyrosine kinase inhibitors. And we rarely do transplants anymore in patients with chronic myelogenous leukemia. This is a true miracle.
And I guess Kareem Abdul-Jabbar would be an example of somebody who's living with CML. The time is shorter than the information we have to convey because Dr. Gregory is terrific. But let's spend a minute or two on the acute leukemias.
Yes.
ALL and AML.
Yes. So what we just talked about were the two chronic leukemias, chronic lymphocytic leukemia, chronic myelogenous leukemia. That has to do with not necessarily how long you live, but with the type of cell. When acute leukemia, these are very young cells. They're not differentiated. They don't grow up. They don't have cells that can fight infection. You get anemic. You can bleed. And in general, they were fatal within a year. We now cure most of the children with acute lymphocytic leukemia. The adult story is not as promising. Adults who get acute myelogenous leukemia, which is the most common leukemia of adults, may go on to cure with chemotherapy, pretty aggressive chemotherapy in the hospital that's given over the course of about a year, in and out of the hospital about a year. And if you have what we call good chromosomes findings for those acute leukemias, you may go on to a cure. Over the age of 65, it really carries with it a much worse prognosis, regardless of whether you have the good chromosomes or the bad chromosomes that make up the acute leukemia. But there are, again, advances being made. We have some oral medications for leukemia in the elderly patients. It's not yet curing these patients, but prolonging life. And so advances are occurring in all of the blood cancers.
And Dr. Gregory was telling me before we went on air, just last month the FDA approved the same Gleevec pill we talked about a little while ago for ALL in children, which is terrific. We have time just for one more area to cover very quickly, like 45 seconds. One of the viewers called and wanted to know what multiple myeloma is, what the risk factors are, how often you see it, what causes it, and how you cure it.
Oh boy, I have how much
Take
time?
60 seconds.
Okay.
Go ahead.
It's another blood cancer. It affects we think of it as the problems, think of the word crab. It affects the calcium level in the blood. It makes calcium come out of bones, so you get holes in bones. Or it affects the renal or the kidney. It affects the blood. You get anemic. And the B is the bone involvement. And so if you have any low back pain, you have anemia, you have to get to your doctor, make sure he does a special test for multiple myeloma. There are cells in the bone marrow called plasma cells. They're very important for the immune system again. They produce immunoglobulins or antibodies. Multiple myeloma is a defect of these productions of these antibodies, and you produce only one type, and so it's called a monoclonal protein that we find in the blood, and those cells actually affect the kidney, the bones, the bone marrow, the blood, and that's why you get holes in bones, you get kidney problems, you get anemia, you get infections, and novel agents today that are really helping patients to live much longer than we use. Patients only live 3 years. 10, 15 years ago. We are prolonging life now, and patients often will go through an autologous bone marrow transplant, stem cell transplant, and we're prolonging life dramatically for multiple myeloma.
Yeah, it's probably the form that needs the most work because patients a lot of times don't have as long of a lifespan as with the other forms of blood cancer. But so much progress is being made.
Absolutely.
So much going on right now in clinical trials. Broken bones are, a lot of times you would not equate that with blood cancer, but that is a lot of times how people come to get...
Yes, and the broken bones can occur with no trauma. So, if I had one patient who just reached into his bathtub to clean the bathtub, and just that movement broke his arm. So these are called pathologic fractures.
That's why, ladies and gentlemen, your host never takes a bath. But anyway, Dr. Gregory, thank you so very much.
Enjoyed it.
Terrific as always. Ladies and gentlemen, we're going to be back here again next Thursday night, 7:30, for Battling and Beating Cancer here on Channel 21 CAN TV. I have to tell you that we're going to be talking about patient navigation, getting through the process from diagnosis to cure, how to make it through, how to navigate the system, tips for patients, and this whole notion, because we're living longer and longer and longer, cancer survivorship. So for Charlene and myself, our thanks to Dr. Gregory,
Thank you, Scott.
to Dorothy, to Christy, our fabulous executive producers, to our CAN TV crew. Thank you. Good night and good health.